My name is Shirley Galenza, and I am the Director for the Centre for Professional Nursing Education. And it is my pleasure to be able to host this series that we have in partnership with Salutaris Centre and 3M. It's been an exciting adventure over the last 3 months that we have come up with this idea to do something for patient education on edema and chronic and lymphedema. So without going into taking too long, I'm going to just introduce the speakers tonight. We have 2 speakers tonight that are going to do a small, short presentation. Will be done probably around 9 o'clock. And at this point in time, there aren't any other handouts than what was there. I know there were some people looking to see if there were handouts, but that's all we have tonight. And so anyways, without going further on, I'm going to introduce Ian Souls. Ian is 19 years of clinical experience treating lymphedema as a Balder certified lymphatic therapist and registered massage therapist. Ian's specialty is manual lymph drainage and combined decongestive therapy. As a result, he receives lymphedema and chronic edema referrals from orthopedic surgeons, oncologists, pain specialists, family physicians, dentists, nurses, physiotherapists, and occupational therapists. Ian has an undergraduate degree in physical education from the University of Alberta and a diploma in massage therapy from MacEwan University. Last year he was our Distinguished Citizen Award in one of our convocations, so he is well known within the community. In 2001, Ian co-founded Salutaris Centre for Lymphatic and Massage Therapy in Edmonton, Alberta, with Diane Kepps. Salutaris Centre is recognized by Alberta Health Services as a comprehensive lymphedema clinic serving cancer and non-cancer related adult and pediatric clients. Ian has delivered sessions on lymphatic therapy to a wide variety of healthcare professionals and patient groups, and has been invited to present a paper in International Lymphedema Framework Conference June 7th in Glasgow, Scotland. He currently sits on the board of North American Balder Association of Lymphatic Therapy and is a member of the Canadian Lymphedema Framework Education Working Group, the National Lymphedema Network, and the International Society of Lymphedema. So, welcome, Ian.
Thank you. Everybody can hear, it's not too loud. Sometimes I kind of get loud. We felt this is a really important topic to talk about, and it kind of developed out of a conversation that we were having with Dr. Verna Yu, who's the Chief Medical Officer in Alberta, based on our concern that patients were having difficulty getting diagnosis and getting treated for this condition. And the idea came up to focus on some patient education, and as we began doing that, it garnered a lot of interest on the part of the healthcare community as well. And we recognize that there's a real mix in the room tonight in terms of patients and healthcare professionals. So we're going to try and walk that fine line between giving you information that's of value to you and not getting too overly technical in terms of how we approach this. My receptionist said to me before you leave, make sure you speak English, Ian. So I'm going to try and do that. What we're going to start with is a look at the anatomy and physiology of the lymphatic system. It's really important to understand what we know about the lymphatic system and what we don't know about the lymphatic system. And at this point in time, the actual physiology and pathophysiology of the lymphatic system is not completely understood. There's many things about it that we don't know how it actually operates. And because understanding physiology and pathophysiology underlie the actual clinical decisions that we make, we feel it's really important that system begin to be more well understood. And until recently, it has been overlooked. In fact, 2 years ago, Stanford University did a study of 120 medical schools across North America, including Canada. And what they in fact found was that all of those schools offered less than 20 minutes education on the lymphatic system. So that kind of explains why we were where we are today. That even though the lymphatic system was identified back when the vascular system was identified, we haven't seen it as being that important within our anatomy, and we haven't in fact done much research on it, and we don't have a lot of education on it today. We're going to first talk about what the lymphatic system does. The first function that it does is an immune function. It produces lymphocytes, it filters, destroys foreign particles, microbes in the body, all of those kinds of things. So it's basically the transportation component of the immune system, and plays a very important role in conjunction with that to pick up antigens and move them to the lymph nodes where they can be identified, and macrophagic activity can take place so they can be gobbled up. Basically, it's the sewer system of the body. But we're not going to focus on that aspect of it with respect to chronic edema and lymphedema. What we're going to talk about is the process of homeostasis. We're going to talk a lot about how the lymphatic system collects, filters, and returns fluid from the interstitial tissues to the bloodstream. So that's those liquidy spaces between your cells in your body, outside of the vascular system, and the role that the lymphatic system plays in actually moving that fluid back into the vascular system. And we're also going to talk about the role that protein, water, fat, cells, and inorganic particle loads have to do with that whole system. So this homeostasis aspect that we got up here, let me try my little thingy. Oh, there we are. This aspect is really where our focus is going to be over the next 3 weeks. This is a very interesting article that was just done recently by some researchers initially out of Japan. It was published in the Oxford Journal. One of the things that they found is that the actual fluid exchange that moves the fluid from our blood supply and back into our blood supply underlies edema and swelling. That the fundamental principle governing how that works was first identified by Starling in 1896. And for 100 years, we have believed what he said to be true. And what he said to be true is that fluids filter from the vascular system into the tissue and then are reabsorbed on the venous side of the blood capillaries. What we know now is that that in fact is not the case. Over the past 25 years, it's become clear that that conventional model does not describe what really happens in terms of microcirculation. The authors note that it's excessive microcirculation, the filtration from the arterial blood supply into the interstitial area, that causes swelling, causes edema, and that it can result from abnormal forces, from increased permeability of the vascular system, caused by inflammation, and it can also, swelling can also happen because of impaired lymphatic drainage. So if you've got some kind of problem with your lymph system. Although textbooks are really persistent and teaching's really persistent about this traditional filtration reabsorption balance, it really has little justification in terms of microcirculation. These are some interesting numbers. Approximately 4 liters of lymph fluid a day is dumped into your subclavian vein up here where we call the lymphatic terminus. You've only got 3 liters approximately of plasma, of fluid in your blood. And 4 liters of that every day is dumped back into the subclavian vein. As well, some later work has shown that roughly half of the fluid content of the lymph is absorbed in microvessels at the lymph nodes as well. So there's a lot of reabsorption going on at the nodes themselves now. So those two combined, the estimated fluid turnover in the body is about 8 liters a day. It's a considerable fluid turnover when you recognize that the total volume is 3 liters, which means that the entire fluid volume of your blood supply leaves your circulation approximately every 9 hours. So you get basically 3 complete fluid changes of your blood over a 24-hour period. Tissue fluid balance thus depends critically on the lymphatic function in most tissues. Okay? That is a position that is entirely different of what we were taught 20 years ago. So what is this lymphatic system? It's a unidirectional, and we've got up here a little diagram of it. It's a unidirectional system, meaning that it flows one way. And it's moved by muscular contraction. It's moved by what's called the Venturi effect, where it's drawn along. I like to say the lymphatic system sucks, it doesn't blow. So you get changes in interthoracic pressure that draws it along. And these things govern the exchange at the capillary levels. The lymphatic load enters initial lymph vessels kind of up here, and they sit primarily in the top 2 layers of the skin, and they kind of look like the fingers of a glove pointing outwards. If this is your skin surface here, they're kind of sticking up like that. And then the lymph fluid is filtered and concentrated in the lymph nodes. The nodes, oval-shaped, kind of bean-like. They're often found in groups. There's about 600 or 700 of them in our bodies, primarily located in our neck, in our axillary areas, in the inguinal areas around the groin. This is what the system looks like as a functional unit. Now, it's really interesting that this diagram up here shows you there's a valve on each end of this little unit. It's called a lymphangion. And it's a separate functioning unit from the unit that's connected next to it. And you get a whole series of these in a row. And they actually have their own pumping capacity. They create their own rhythm. They usually work at about 5 to 10% of their capacity. So they're kind of sluggish, lazy little things. And they return 2 to 4 liters of fluid daily, which can increase with exercise. And in fact, you can increase the pulsations of these about 10 to 30 pulsations as opposed to 6 to 10. So anywhere between 6 and 10 times the actual resting rate, you can accelerate these. And that becomes important when we talk a little later, when I start talking about manual lymphatic drainage and the role that it has in stimulating lymph flow. These are what these look like. This is from Flinders University in Australia. And basically, the initial lymph vessel looks like this. It's a single layer of what's called endothelial cells. It's a very delicate system. It's held in place by filaments. It's a very leaky system, so that, in fact, proteins, large fat molecules, inorganic and organic matter can actually go into these, but it can go in and out. So you have to actually be very gentle when you're trying to stimulate the lymphatic system. 60 to 70% of the lymphatic system's in the top 2 layers of your skin. So if the weight that you're using for the massage is more than the weight of a nickel on the skin, then you're probably just pushing lymph fluid into the system and out of the system and into the system and out of the system, and it's not going anywhere. Our body is made up of lymphatic watersheds. so that different parts of our bodies drain to different areas, much the same way as a field drains or as an area with hills and valleys. The body's divided into separate regions, and it says here they have superficial anamostases, meaning there's actually superficial valves between the different watersheds. So you get in a situation that you can actually superficially move fluid between the left and right side of the body. You can't actually move fluid, or nobody's actually demonstrated it yet, although they teach it in terms of lymphatic massage. Nobody's actually imaged being able to move fluid inferiorly, but you can move it superiorly. Either side of these divisions, the flow is in the opposite direction. So from the midline of the sternum, the left side will drain to the axillary lymph nodes, the right side will drain to the right axillary lymph nodes. The other line that's an important watershed is here at the navel lumbar line. And it divides what drains basically south and what drains north. Most of the lymphatic system's in the dermis, in the top two layers of the skin, and they can act as collateral routes for fluid retention. This is an interesting dynamic, and nobody has yet explained why this is. But these are the different watersheds for the left and right terminus. Remember I said that the lymphatic system dumps into the subclavian up here by the collarbone. And on the right side, half of the head, half of the thorax, and the right arm drains into the right terminus, and the entire rest of the body drains into the left. If you can figure that one out, you probably get something published. Let's talk about the factors that affect lymph flow. There's quite a number of them that affect it, and they can disrupt it in combination or disrupt it by themselves. Things like obesity, and we're seeing an increasing amount of lymphedema as a result of increased obesity within our society. Venous insufficiency, cardiac insufficiency, renal failure. Some of these things we can't do anything about with respect to combined decongestive therapy. In fact, to move fluids in some of these instances, such as cardiac insufficiency or renal failure, is contraindicated. Shallow breathing. Remember I said the lymphatic system sucked, it didn't blow. So if you're not breathing really deeply, if your diaphragm's not moving, you're not moving as much lymph flow. Constipation, lymphatic obstruction, sedentary lifestyles, and immobility. We're starting to see a lot of lymphedema in home care settings, or I'm sure you are more than I am in some of these cases, where it's a result of people being immobile. There's genetic predispositions. Inflammation affects lymphatic flow, surgery, trauma, radiation, node dissections, all of those are pretty common. Scar tissue formation, adhesions, myofascial restrictions, all of those kinds of things impact lymphatic flow in the body. This is an interesting study. This Dr. Lian Shao actually has just moved to the University of Calgary to take part in a lymphatic research initiative that we've actually recently got underway down there. And they say lymph flow is determined by lymphatic production and active and passive forces on lymphatic vessels. That's what's traditionally been known. The lymphatic vessels can produce flow on their own using smooth muscle contractions to drive that fluid. And it's driven in a one-way direction through one-way valves and lymph nodes before it's returned to the blood supply. Although there's studies about lymphatic pumping and insights into lymphatic contraction, the molecular control of this process is not well understood. And for the longest time, we have thought that lymphedema is all about protein levels. This study determined how lymphatic contraction is actually altered under inflammatory conditions. And what the researchers did is they induced inflammation, and they then were able to detect larger lymph vessel diameters, abnormal smooth muscle contraction, and reduced lymphatic flow. And then they demonstrated that nitric oxide in the form of eNOS actually caused robust lymphatic contractions. But then they also found that by contrast, when the tissue was inflamed, inducible eNOS expressed cells that stopped smooth muscle contraction. So we now know that inflammatory agents secreting eNOS can actually stop smooth muscle contraction in the lymphatic system. And they found that the inflammation and cancer dissemination shared many features in the alterations of both the structure and function of lymph vessels, including lymphangiogenesis and vessel dilation. And they found that although lymphangiogenesis and vessel dilation, so the vessels getting bigger, are thought to increase the delivery of lymph, so move more lymph, it actually decreased drainage during inflammation. Another interesting study that's just recently been out is by a group over in Korea. And they found a number of lymphedema patients with protein concentration levels lower in their lymphedema tissue than in their normal tissue. Now, we've all thought for years now that lymphedema was all about high protein levels. And they were finding situations where they had lymphedema and low protein levels. But what they found was that hyaluronic acid levels were clearly higher in lymphedema tissue than in normal. And hyaluronic acid hampers cell trafficking. It triggers cytokines, which are inflammatory agents, and results in changes in the tissue associated with chronic lymphedema. So lymphedema, which is viewed as a high protein lymphedema, actually shows a stronger correlation to this hyaluronic acid being present in the tissue than to protein levels. And that's very new. As the lymphatic system is the main transportation component pathway for hyaluronic acid, the tissue impairs the lymphatic circulation and promotes stagnation and changes the metabolism of the tissue. And it initiates inflammation, which affects collagen mechanisms and causes fibrosis, and you get actual tissue changes going on. Then what they did a follow-up study in 2013, and they wanted to test that. So they tested it, they created edemas in the tails of mice. And then they noted that Dr. Fodi in Germany found that there were higher gene expressions for cytokines in untreated patients compared with those treated with combined decongestive therapy. So if they just looked at people that had lymphedema and had no treatment, they found cytokine levels really high. In people that had combined decongestive therapy, being manual lymph drainage and compression, those levels were a lot lower. They postulated that inflammation is central to the issue of lymphedema, creating fibrosis in the transition phase from acute to chronic lymphedema. Dr. Yan's going to talk about venous insufficiency and chronic edema, and I'm going to show you a little slide here coming up about the progression from acute to lymphedema. But what they found here is that inflammation is central to that process of moving along and having your swelling not going away. The study researched, they took an enzyme and they injected into the tails of these mice to see whether or not they were right about the hyaluronic acid. And what they found actually was that the enzyme reduced the lymphedema volume and the underlying mechanisms, may be a reduction in hyaluronic acid trafficking, and it reduces inflammation, it reduced fibrosis, and it stimulated lymphangiogenesis. So they resolved the lymphedema in the mouse tails by injecting them with this enzyme, which suggests that even though the protein levels were high, if they took care of the inflammation, they could stop the lymphedema. So this is basically a quick little summary. Lymphatic system is a one-way system. It's dynamic with the ability to have great variances in fuel volumes. It's vital for fluid homeostasis, for the balance of fluid in our body, and for the immune system, and it's dependent on intrinsic and extrinsic factors. Alrighty, let's talk a little bit about types of edema. This slide's kind of an important one, and I'm going to spend a little bit of time on it here because it kind of sets up what Dr. Yan's going to be talking about next. Across the top, you'll notice that we're talking about, acute edema, chronic edema, lymphedema, and phlebolymphedema. The durations are interesting. Basically, acute edema it's short-lived. It's self-limiting. You sprain an ankle, it gets better. The duration of chronic edema, however, is greater than 3 months. You sprain your ankle, you have some kind of car accident, a seat belt across you, you get cellulitis, you find your edema doesn't go away. It's been hanging around about 3 months or so. You're now into a chronic edema phase. And with lymphedema, it's a lifelong chronic condition of swelling. Okay? At this point in time, there is not a cure. You can manage it, you can improve it, but you can't fix it. In phlebolymphedema, you have a combined chronic venous insufficiency with a related edema and lymphedema. So you get high protein levels, you get a lot of inflammation. The pathophysiology of all of them is all the same. It's basically an imbalance between the filtration of the fluid from the vascular system into the tissue and the reabsorption. The etiology, how it actually happens, changes. In acute edema, you get a natural occurrence due to local tissue trauma. In a chronic edema, sometimes you've got systemic disturbances like chronic heart failure, chronic liver disease, kidney disease, venous disease, or complications of mobility, those kinds of things. In a lymphedema, you can either have a congenital acquired lymphedema or you can have a pathway disturbance, which is called a secondary lymphedema. And we're going to cover that a little bit more here too. And a phlebolymphedema is due to venous insufficiency and eventual disruption of the lymphatic vessels. The lymphatic involvement in an acute edema, it's temporarily disrupted. It repairs itself. You go on and get better. In a chronic edema, the lymphatic system's intact, but it gets impaired over time. And that goes back, I think, to that whole notion about inflammation. And in lymphedema, the lymphatic system is impaired or destructed, and it can be either structural or functional. And then in the phlebolymphedema, the disruption is due to repeated inflammatory processes, they believe. Tissue protein, it's low in acute edema. It's fairly low in a chronic edema initially, but it moves towards being higher. Those large proteins are not taken away by the lymphatic system, so they begin to stay in the tissue. A lymphedema has a high protein content in the tissue, which causes osmosis to happen. You get increased rates of filtration across the vascular membrane, so you continue to swell more and more and more. The issue in the whole lymphedema treatment protocol becomes, how do you actually manage the lymphedema if you don't change the physiology of the tissue? If you can't reduce the protein level or the inflammatory level of the tissue, how do you actually reduce the amount of lymphedema, of edema in the area? One of the things we see quite a lot of actually is diuretic prescription for lymphedema, which is actually contraindicated, because if you give a patient diuretics, you've taken the fluid away, but now the protein concentration is even higher than it was before you started. And now the rate of filtration is even faster than it once was. So you get into this whole problem. The same thing is true with a lot of pneumatic pumps. You take a pneumatic pump and you put it on a limb, and it pumps all of the protein and fluid up to the top of the limb, but it can't go anywhere past the top of the sleeve. And then it becomes fibrotic and further disrupts the lymph flow that you've already gotten compromised, and now you've got a bigger problem. So I'm not against the use of pneumatic pumps. I'm against the use of solely pneumatic pumps. If you use pneumatic pumps in combination with lymphatic drainage to move those proteins across a watershed into another watershed, then in fact you've got a different situation. But if you're just pumping, you've got a problem. And then with phlebital lymphedema, you've got high protein content as well. The management for acute edema is generally manage the symptoms. In chronic edema, you manage the cause of it early and compression, and then lymphedema, you get a more intensive of therapies. Okay, types of lymphedema. Basically, they're categorized into two categories: primary or congenital, which has something to do with our genetic makeup, or secondary or acquired lymphedema. Although they're categories in this way, what you typically see in a clinical setting is lymphedemas are treated as cancer or non-cancer related. So you get situations where there's a number of different congenital problems that create a lymphedema, or in a secondary side of things, you can have infections or trauma, or you can have tumors or primary tumor reoccurrences, metastases. So you can have a trauma that is a non-cancer related lymphedema, such as a car accident or a hip or knee replacement, or you can have an infection, or you can have a trauma that is cancer related, such as radiation or surgery, those kinds of things. So we tend to talk more about cancer and non-cancer related lymphedemas than primary or secondary. Although progression is different, in a primary lymphedema, the edema tends to start distally first and then work its way up. So it appears first in the foot and works its way up the leg. In a secondary lymphedema, it tends to be the other direction, although that's not gospel because I've seen it go the other way too. Primary lymphedema, it's accumulation of protein-rich fluid in the tissue caused by an impairment of the lymphatic system. Interesting thing about primary lymphedema is right here. 87% of the primary lymphedema patients are female compared to 13% male. The Milroy type occurs usually around birth or shortly after, so we'll see it between sort of 0 and 6 months, mostly in the lower extremities. And the other type occurs around or before age 35 or after age 35. Interesting thing about this lymphedema is 87% of primary lymphedema patients are primarily women. We see it at really hormonal times in their lives. So although there hasn't been any real research around this whole area, I think that's probably a lot to do with the endocrine system. Because you see it between 0 and 6 months, you see it around puberty, you see it perimenopausal, menopausal, and you see it after pregnancies. All of those times, all of those situations, in my view, have one common feature, and that is shifts in hormones. 3 different reasons that can happen structurally with respect to lymphedema. There can be a lack of growth of the lymphatic vessels, may also affect the nodes. There can be too many vessels, but a lack of function, or they're too dilated, or there can be superficial, a lack of superficial collectors, so those little finger-like projections aren't there. So there's no way to pick up fluid in the superficial and enter it. This is an interesting slide. These people both have primary lymphedema. Can you tell which leg is the lymphatic edematous leg? It's fairly obvious on the right, on the left-hand one, but yeah, it's the right one. So that's the start of it. That's what it looks like when you get it early. This is what it looks like when you don't manage it properly. And it can get bad. We've got situations in Alberta that are this severe, which is shocking to me. Primary lymphedema is due to an impairment of lymph transport due to the malfunctioning of the lymph vessels. It can be seen at birth, puberty, pregnancy, not until later in life, and the incidence higher in females than males, and there's a genetic disposition. Secondary lymphedema, the one that's caused by some kind of disruption to the system, is caused by a number of features. The first we're going to talk about a little bit is trauma and tissue damage. Lymph nodes are excised in cancer situations. You get radiation, which basically burns off the lymphatic vessels in the radiated areas. You can have burns that you actually get just in your living. I worked on a gentleman one time. He was in a rollover accident on a tractor. He was burned from his nipples to the soles of his feet and began to develop lymphedema in both of his legs. Varicose vein surgery can cause it in some instances, or harvesting veins. Large circumferential wounds. I worked on a gentleman one time who was in an industrial accident and basically lost all the tissue off his forearm all the way around. His hand blew up because there's no lymphatic vessels then there. But even in those situations, you can move the fluid under the scar tissue. And we actually had some success in terms of reducing his hand, getting him back into therapy and back into work. Post-surgical drains and wound complications can cause lymphedema. So anything that actually disrupts or damages the tissue. Malignant diseases, metastases, pressure from large tumors. You'll see those in palliative situations a number of times. Venous disease, chronic venous insufficiency, post-traumatic syndrome, DVTs. I've seen lymphedemas develop after people have had DVTs. Infections. Dr. Rao on the 21st is going to be talking about the dermatological conditions resulting from lymphedema. Cellulitis, filariasis, those kinds of things are some of the infections that we're concerned about when you're at risk being a lymphedema patient. And inflammation can cause it. Rheumatoid arthritis, I've seen rheumatoid arthritis patients with lymphedema below the joints that are inflamed, psoriasis. And we're seeing more and more of dependency edemas and paralysis. People that are in bed or in chairs can't get around as well. That causes more and more. This is a lymph scintigraphy. It is possible to map the lymphatic system. We don't generally do it. What you've got here, this is the patient actually, and she was injected with a radioactive isotope in her hand, and then 19 minutes later, using a nuclear medicine unit, they actually were able to map what had happened to that radioactive isotope, and you can see how it's begun moving up, but it's pooling in her hand here. And this is the left side that's unaffected, as you can see. And you can see some of the pathway actually all the way up here to the terminus. 3.5 hours later, when they imaged it again, you can see that there is no flow out of this arm. All the radioactive isotopes are still in the tissue here. And on the left side, there's basically some at the site of the injection, but the arm is all clear. In fact, it's moved the radioactive isotopes out into the kidneys. They're starting to appear. So lymph scintigraphy is something that's being used more in the US and a lot in Europe. There's a doctor at the University of Arizona who actually sees nothing but lymphedema patients, and she won't see one without a lymph scintigraphy. She says a cardiologist doesn't see a heart patient without all the results. Why would I? What's the prevalence? This is an interesting discussion that we always get into, is how many lymphedema patients are there? How many are there in Alberta? The rate at birth is about 1 in 6,000 will develop primary lymphedema. The overall prevalence of lymphedema and chronic edema has been estimated in the population to be around 2%. In developed countries, the main cause of lymphedema is widely assumed to be treatment for cancer. the best prevalence study that's been done, and we're going to get to it and look at some of the stats from it. It was done in London in the UK by Dr. Christine Moffat, who's actually going to be in Edmonton on the 7th of May. What she found is, in fact, 60% of lymphedema patients are non-cancer related. It's due to primary or secondary reasons that have nothing to do with cancer. Our focus in this country has been about cancer, and particularly breast cancer. But there's a lot more lymphedema patients out there that aren't getting treated and aren't getting diagnosed, aren't getting seen in our communities that have nothing to do with cancer. And currently, they've got limited options in terms of treatment. The prevalences are up to 70% have been reported in breast cancers, although the commonly accepted rate is around 30%. 28 to 47% of patients treated for gynecological cancers will develop lymphedema. And about 1/4 to 1/2 of effective patients suffer from other forms of lymphedema that aren't associated with cancer, that have to do with primary or venous function or trauma. Axillary node dissections, everybody's stats are different. They're 12 to 70% sentinel node dissections. You sort of wonder, you know, how do you get such a big variance here in terms of 12 to 70%? It's interesting, actually. Some of that has to do with how you define lymphedema. And there's all kinds of debate in the clinical community about, you know, is it 20% arm volume difference between the affected and the unaffected side? Is it 2 centimeters of circumference difference? What is it? So depending on the study and what definition they used, that affects the kind of numbers they report in terms of lymphedema. Lower leg extremities, these are the different numbers each of these guys have found associated with the lower ones. Most people develop lymphedema within 2 years post-surgery, or 2 years of the trauma that caused it. Although we have seen people develop lymphedema for up to 30 years after. So if you've had surgery, radiation, an accident that has caused disruption to your lymphatic system, you are at risk for lymphedema and you are at risk the rest of your life. This is a prevalence study in London. They found 283 patients in 619,000 people had chronic edema. 32% were receiving some form of compression bandaging. So there was a lot of people that weren't having treatment. 29% had an infection in the last 12 months. 27% were admitted for IV antibiotics, mean stay of 12 days at a cost of £2,300, which is, what, about $5,000. 80% had taken time off work. So there's some real impacts here in terms of lifestyle and the ability to get on with working. 8% had to give up work. And they found that for every pound spent on lymphedema treatment in the UK, they save £100 in reduced hospital admissions. They were able to prove that statistic, and it has done absolutely nothing in terms of changing the way lymphedema is treated in the UK. As I've said to the past 3 health ministers in Alberta, one of the things that really bugs me is fiscal conservatives that can't add. We keep talking about the treatment of lymphedema as a cost and not as an investment in a cost saving in the system. And we need to do a much better job at identifying what the impact of that is. Okay, what about Alberta? There is no prevalence studies. We've had a health economist go in and they went into the data and they looked through the physician codes and they couldn't come up with much for lymphedema because nobody's coding it. So the health economist pretty much found 0. We took Moffat's stats and Canadian Cancer stats and Alberta Treasury population projections, and we applied those in Alberta. And these are the numbers that I came up with. Based on all of those statistics, in 2011 there was approximately 6,700 lymphedema patients in the province, if Moffat's study was any good, which I think it was. And in 2016 we'll be looking at about 7,600. I think in fact those numbers are very conservative. And one of the things that actually causes me to think that even more so today than I did yesterday is we had over 100 people register to spend 6 hours of their life over the next 3 weeks talking about lymphedema and chronic edema. So there must be a lot of people out in the community having to struggle with this. The other thing is we set up a website at Salutaris Centre that has research and it has information about clinical practices and how to treat it and all those kind of things. It's visited during any 30-day period by approximately 300 new non-bounce visitors. Those are people spending an average of 6 minutes on the site. And you know what? I don't think you're bored on a Friday night, you go to a lymphedema site and hang out for 6 minutes. You must know somebody or have an issue with respect to edema that you're trying to solve. 33% of those people are local to the Edmonton area. That's approximately 100 people. That's 100 people every 30 days in the city of Edmonton that are spending on average 6 minutes on our site looking at lymphedema information. 55% of our visitors are Canadian, 80% are North American, and 20% are global. So all of that says to me that this is a real issue. It's one that we need to begin to understand more. We have to start with understanding the anatomy and the physiology. We need that to inform the clinical practices so that we don't just continue to ignore this issue, or we don't treat it in a way that we think is cost effective when it doesn't in fact change the physiology of the tissue, and it doesn't in fact respect the way the system actually works. So I wanted to start tonight in terms of this next 6 hours we're going to spend with you, giving you some understanding of the lymphatic anatomy and physiology and pathophysiology, and I'm sure it's kind of some of it's glazed over and bored you to tears, and I hope you've gotten something from the rest of it. If anybody has any questions for the next few minutes, I can take some, and then and Dr. Yan can come and tell you about chronic venous insufficiency and a whole lot of other chronic edema issues. Questions?
In the primary, is it more noticeable in the lower extremities?
Yeah, primary lymphedema tends to be almost exclusively lower extremities. Although I should qualify that, you see it abdominally and pelvis as well, but you tend to see it a lot less in terms of the arms and the thorax.
The movement of the lymph, I'm just wondering, does it have its own system in the sense of like arteries pump blood, or is it just your body movement that moves the lymph?
Well, that's one of the things that we're not entirely certain about. Okay. It's a one-way system. It's got valves in it, and each of those lymph units has smooth muscle around it that squeezes it along. Okay. What they're beginning to wonder in research right now is whether or not the lymph node actually has a role in regulating the flow and the amount of lymph. They've identified that some cells in the lymph angion, in that little unit that I showed you earlier, that they think might be similar to the SA node in the heart that can sequence the pumping of the lymphatic system. But much of it is moved through arteries pumping, through muscular contraction, through changes in thoracic pressure, and draws the fluid along as a result of the Venturi effect. But there's also a contractile component to it that can be increased with exercise and can be increased with massage, with gentle massage. So it's got its own pumping capacity. It doesn't have a pump like a heart. It's got a whole bunch of individual pumps, just like you might have pumps along a pipeline.
Okay, thank you.
Bob?
How much success have you had with pre and post knee surgery with the increased healing rate?
We've had lots, haven't we? In fact, your knees. Yeah, you know, there's some really good results that we're getting with post-operative complete joint replacements. In fact, Dr. Don Weber, who's the chief of orthopedics for the Capital Region, is quite interested in the work that we're doing for manual lymphatic drainage for the treatment of complete joint replacement because of some of the results that he's seen us get with some of his patients. We're also using manual lymph drainage. Anytime you can reduce edema, I had a 68-year-old woman fracture the humerus, osteoporosis, and we did 5 days a week of manual lymph drainage for 4 weeks. She got a complete fracture. They x-rayed it. I worked right over the fracture site on the first day that it was fractured. She was in a sling so we could take it out. And 4 weeks later, they x-rayed it again. At the time, the orthopedic that looked at that x-ray said, there's no way this is a 4-week-old fracture. It's got to be 6 or 7 for the amount of healing that's taken place. Now, why would that healing be accelerated? The reason I believe it would is because the inflammatory agents are moved out of the tissue. The amount of edema between the vascular system and the live cells is narrower, and how long it takes nutrients to cross that interstitial boundary of fluid, time equals distance squared. So just for easy numbers' sake, if it takes 2 seconds to move across 2 centimeters, and that 2 centimeter distance is now 4 centimeters, it now takes 16 seconds for those nutrients or those dead cell particles to move across that barrier. So if you reduce the amount of edema more quickly, you can in fact increase the amount of nutrients that are getting to that site, increase the amount of dead cell particles and inflammatory agents out of that area, and actually accelerate the healing. And we've got an x-ray to prove it.
When you say that the lymphatic tissue is inflamed, that inflammation plays a big role, is there any role for systemic anti-inflammatories to help reduce that what's occurring? Like
Why don't you ask Michael when he comes up here next? Because that's out of my realm. You know, I am not a physician, so I don't know. You know, we've got there's a physician in town actually that's looking at this whole hyaluronic acid thing, because I guess one of the things that I was wondering about is if we took hyaluronic acid, put it in a cream, and put it on the leg, could we reduce the amount of hyaluronic acid? Apparently, it doesn't work that simply because it doesn't cross the skin barrier.
That was my question, is hyaluronic acid, like, can you tell us more about this? Like, where does this, how does it get in your system, or what?
It's in our body. It's secreted by inflammatory agents. It has a role of increasing inflammation for whatever reason.
Does it actually get inflammation that actually creates more of this stuff in your system, or it builds more of it, or?
Yeah, you know what, I don't know the specific answer to that question either. Whether or not, I would think the answer to that is yes, but I'm not sure. Again, maybe Dr. Yan knows.
It seems like you were kind of honing in on that, and it seemed like that was part of the culprit here with a lot of.
I think it is part of the culprit. It was just that whole area has just started to be developed. As you notice, that research was 2013, so. This is really new stuff, and there's a lot of unanswered questions about it. Maybe we should wrap up me and let Michael have a go here.
Well, I think we will. Thank you very much, Ian. That was